Can you see my screen?
Yes, it's on Parkinson's.
Yes.
All right.
Yes.
So in Parkinson's, what makes this different?
Can't hear you.
No, you have to email it to me. All right, sorry about that. So if you compare this to Guillain-Barré, in Guillain-Barré, that was a autoimmune disorder affecting so your body developed autoantibodies against your acetylcholine receptor sites. There was no problem there with the neurotransmitter, no problem with acetylcholine, no problem with dopamine. So quick review, acetylcholine and dopamine are both neurotransmitters. In acetylcholine, it makes muscle contraction, muscle movement possible, whereas dopamine gives you control over those muscle movements. So the problem here is um, a underproduction of dopamine. So the patients with Parkinson's disease, they lack dopamine. So dopamine is produced in the substantia nigra, and we don't know the exact cause, although we can attribute it to a few causes, but we don't exactly know what causes Parkinson's disease. There are a few um, made stated idiopathic, so we don't know. Some have been linked to pesticides or from brain injury, brain tumors. So those are some. There are also some medications, particularly Haldol, which is an antipsychotic medication. They can produce Parkinsonism, meaning they cause symptoms of Parkinson's disease. That is the prolonged use or repeated use of Haldol. So you've probably seen it in. Have you seen those patients in Woodhall, wherein they pretty much live in the hospital? Have you, or in a psych facility, have you seen patients like that who've been on Haldol for an extended period of time and then they become robots? Have you noticed that?
No, I haven't
Yes.
seen.
Yes, some of those are induced by Haldol. So the more we use Haldol, the more Parkinson symptoms they develop as a result. So please read the
Professor, but
yeah.
if you stop the medication, it could be reversible, correct?
Generally, yes, the symptoms improve, but sometimes, occasionally, there are a few patients that remain permanently with Parkinsonism.
Okay, thank you.
So that's the long story short. If you read the whole paragraph, so we basically don't have enough dopamine, and we need dopamine in order to have control over muscle contraction. So we don't have that, so that's why the patient results in these tremors. It's different from later we'll talk about multiple sclerosis. The tremors in multiple sclerosis is um, intention tremors, whereas the tremors um, here in Parkinson's is more on resting tremors. We'll compare it later when we get to multiple sclerosis. So the the hallmark features of Parkinson's disease is TRAP, T-R-A-P. So we have tremors, particularly these are resting tremors. We have rigidity or muscle rigidity. And then also we have akinesia, or it could also be bradykinesia. And then finally we have postural instability. So that's TRAP.
How do I do that?
So patients would look like this. It may seem like the patient has cognitive dysfunction, but they don't. You clearly see that in famous celebrities who have developed Parkinson's, namely Muhammad Ali, and we have Michael J. Fox. Those individuals never lost cognitive function. They were as sharp as they were before they developed the disease. So that's one thing to remember. It's you can easily be deceived because they have this mask-like face, meaning they have absolutely no emotion. Okay, they cannot have any um, facial expressions as a result of the disease. So this is the typical posture, regardless of who it is. Um, they have the same appearance. The diagnostic tests, of course, is we draw clinical symptoms and then combine with CAT scan because we have to rule out other causes. If you compare Parkinson's with Alzheimer's disease, in Alzheimer's disease, there is a shrinking of the brain mass, which shows deterioration of the entire brain. In Parkinson's, that doesn't happen. You just have these in the substantia nigra, there is a considerable decrease in the level. So you draw blood tests also, you will show decreased dopamine levels. And if you remember, dopamine is also a vasopressor, correct? It maintains blood pressure. So therefore, if you have low dopamine levels, what do you think will be these patients' blood pressure as well? There will be hypotension, which will accompany the disorder. So both the disorder and some medications that they will be taking will all contribute to hypotension, which will put these patients at risk for fall. Mainstay of Parkinson's treatment is drug therapy, along with speech and as well as physical therapy, just to maintain function. Our number one concern is, in addition to falls, is aspiration. Surprisingly, there are multiple people in the United States living alone with Parkinson's, meaning they can still function fine with um, good medication management. They can independently function. Some are more fortunate; they have family members, but unfortunately, some do not have that. They live alone. However, they are monitored. We have telemedicine, so we monitor them. Um, no, remotely. They meet with a nurse or a doctor over the internet. Either Zoom or whatever meeting online meetings, media. So we can still manage it there as long as they're still able to function independently. Of course, we try not to put them in institutions. So these are the mainstay medications. There are several. The reason is what will happen if you take the same medication over 10 years, 20 years? What's going to happen if you take this
Tolerance.
medication? All right.
You need to increase the dose.
Right, so you can easily develop tolerance to these medications. So that's why you'll see several here which work in different ways and they will be alternated. The therapy, as far as which ones to begin first, of course, that's the doctors and the patients. They agree on which medication to start them on first. There are several things to consider here. We have insurance, we have individual side effects on the patient, depends on the age of the patient. because some medications, let's say anticholinergic medications, like these two here, terhexyphenidyl and benztropine, these are anticholinergic drugs, which of course, what will happen if you give this to older adults, as stated here? If you have an older patient, will it be pleasant?
Urinary retention.
Yeah, they have these effects um, are not good for the elderly. So this is what I mean by the choice of the medication really depends on several factors. Number one is the age of the patient. Younger patients can tolerate these two drugs. Uh, of course, the elderly, which they may have comorbidities as well, on top of Parkinson's. What if you have a patient who has heart failure or renal disease, for instance? What will happen if they have this water retention caused by anticholinergics? So it will exacerbate the conditions, correct? So the choices will depend. These are drug questions, so prepare for answering side effects, just whatever's on your textbook. So side effects mainly, and then your, of course, nursing responsibilities regarding those side effects. What to teach the patient to expect, what to teach the patient to report. So after anticholinergics, we have dopamine receptor agonists, Mirapex or pramipexole, or ropinirole. You probably heard of this drug for restless leg syndrome. It's also used for Parkinson's. These are the unpleasant side effects related to dopamine receptor agonists. Patients, as I mentioned earlier, the cheapest drug, by the way, on which most patients are started on, is Cinemet. Cinemet is carbidopa, levodopa. So there's two drugs in here because you know about the blood-brain barrier, right? What does the blood-brain barrier do? What is it?
It prevents bacteria and other stuff from
Okay,
going
so it
into the brain.
protects the brain, right? So it's
Yeah.
also it also can work against Parkinson's therapy, though. That's why there's not so many drugs we can use because of the blood-brain barrier. Another reason for why they combine these two is levodopa is dopamine. When it crosses over, it is most of it is destroyed. So therefore, they give it with carbidopa. The intention is to prevent its destruction when it crosses the blood-brain barrier, resulting in more levodopa levels as it crosses. Because most drugs are destroyed because of the blood-brain barrier. So when they give these two drugs, the combination allows for higher levels of dopamine left over, even if some destruction occurs. So they prevent the conversion of levodopa um, to dopamine by combining the two drugs, okay, leaving the patient with more dopamine as a result. So if you look at the combination drugs here, the therapy is either to increase the dopamine, meaning you give them dopamine, which is levodopa, or you stimulate the receptor sites for dopamine, um, or increase the production of dopamine, which is in anticholinergic medications.
So, Professor, you would never give you would never give carbidopa alone, right? You would always do it with levodopa.
Neither drug, yeah, they give it as Cinemet, which is the combination of both drugs.
Okay.
There are other drugs not listed here. We have entacapone, which is I don't know what the forgot what the generic, I mean the brand name for entacapone is. And it's COMT2 inhibitors, but that drug is expensive. You'll have to plead with Medicare to approve it. But it's also a great addition to the therapy. But it's not mentioned here, so never mind. But if you get it on the NCLEX, it's called entacapone. It's a COMT2 inhibitor. It's another option for these drugs. Okay, so the oldest drugs are cogentin. These are the most I've seen this in since I was in nursing school. So these are the oldest drugs, cogentin and cinnamon. These are the oldest drugs used for Parkinson's disease. So we talked about earlier the tolerance, right? So the drug therapy will eventually cause tolerance, and this will be manifested in freezing and freezing episodes, or freezing meaning they are off states. Okay, the drugs wear off, meaning the patient develops tolerance and the drugs no longer work. So it is really during these off periods that the patient's symptoms, namely um, the akinesia, which is no movement or very slow movement, bradykinesia, the tremors, once these symptoms start to appear, that means the patient now has a wearing off state. And that is the time they call their doctor, and then they'll be asked to come in, and then they'll change the medications again. Um, and there will be a time wherein, let's say, after 20 years or more of treatment, these patients, just like opioid um, opioid dependent patients, these patients will be asked to go on a drug holiday, meaning after several changes in medications, if they come to a point wherein they will have um, severe or frequent freezing episodes or wearing off episodes, they will be put on a drug holiday. But that is a last resort, and usually they're either closely monitored at home or they'll be admitted to the hospital during a drug holiday, because all those symptoms will be increased, because imagine them being taken off all medications, meaning no drug therapy at all. So they'll have the trap, they'll have the tremors, which will make eating very difficult. Swallowing, there'll be a high risk for aspiration. Um, but that's like a last resort. Okay, if none of the drug therapy work, then they'll have to be put on a drug holiday. The beauty about drug holidays, after that period, which is around a week, they take them off drug therapy for a week. When they resume the drug therapy, they work like magic. It's like the first time they're taking the medications again, and then it works beautifully, right? So that's the benefit of a drug holiday. However, it's dangerous though when you take them off all the medications. That's why they have to be um,
And
either hospitalized. They'll have to be an inpatient, or at least monitored closely at home.
Professor, and how many times do they do this drug holiday, or is it just one time that they do it?
That's very, again, it's very dangerous when they do that last resort option. So it's not very common.
And they put them back on the same drug again.
Yes, and it'll be like the first time they're taking it. They work effectively again.
Oh, does it wear off again, like as they're taking it for a long
Eventually,
period of time?
yeah. Uh-huh. So that's why we go through the same thing again. So after a long time, we change to a different drug, and then do the same. We just keep changing medications to maintain the patient, because this is chronic. There's no cure.
Right. Exactly.
As far as surgical management, will disregard this, because how many people have you seen that had cure or yeah, from Parkinson's? You think Michael J. Fox can afford surgery?
Of course he can,
He
but
Yeah, so
can.
none of them had, because the success rate of these surgeries aren't very good. So based on history, there's really not much that surgical management can do. There are non, not involving craniotomy. They can just do a burl hole instead of opening up the whole brain. They can do that with electrodes, but again, they're still on drug therapy.
Professor,
Yes.
Professor, I know, like, I have a family member. Actually, it's my mother-in-law. She has Parkinson, and when she like but she doesn't live here. So when she is in a very, very, very intense stage, she
Uh-huh.
gets electroshocks.
Okay, but
So is that something that I should tell them not to get done?
no, no, no. I mean, I'm not a doctor. Is it helping her though?
I mean, I think she's then in a hospital for 2 weeks or so. It's very horrible situation, and then after that, she's again on drugs. I mean, it helps at
That's
the end when she's
you know,
back on
I
drugs, but
mean, that's my point. It's up to the patient. I'm not one to give advice. I mean, I'm a nurse. All right, so these are what they're referring to here as, this ones though are mild electrical stimulation. This is not involving those electric shocks. So there are therapies not mentioned in the textbook. So it's up to the patient and their caregiver really. But like you said, it doesn't give that much benefit, right?
yes. Uh-huh.
And maybe for a short time, I don't know if it makes it worth it.
I don't know. She doesn't live here. I don't see her all the time, but I know she's like, it's a very
How
tough
she now?
um, thing. Yeah.
How old is she now?
She is in her 60s, late 60s.
Okay, so still very young. Okay, yeah, I
Uh-huh.
can understand why she would um, receive the treatment. So yeah, I mean she's quite young.
And she has it for a long time now, also.
Yep.
Thanks, Professor.
All right. So summary. So patients with Parkinson's, this is again a chronic illness. It's a debilitating illness. The Some of the complications not mentioned here are, of course, psychosocial. Imagine if, let's use your aunt for instance. How old was she when she was first diagnosed?
Like in her late 30s.
Okay, imagine you're in your 30s and then you have these symptoms here. You have trap, right? You have
Mm-hmm.
the resting tremors. You have the muscle rigidity, or muscle you can't move them, either they're rigid or very hard to move. Then you have the um, shuffling gait, okay, the postural instability. You walk like,
Yeah.
and then of course the mask-like face. The plus when you move the shuffling gait, it's like, imagine you are being propelled forward. Okay, so your body is in a stoop posture, in a forward leaning posture. You know the Michael Jackson when he does that, I think it was Smooth Criminal, that dance. You remember his performance when he was
Yes.
in this white suit with a really fancy hat, and he'd lean
Yes.
forward like
Yes.
that. So imagine you're walking like that. So you're leaning forward, but then you shuffle. Okay, you can't um, lift your legs. You're just dragging your feet forward. All right, and then you're 30 years old, and you have all these symptoms. Okay, plus the mask-like face. You have no expression. Okay, so what psychosocial side effects do you see?
Depression.
Okay, so these patients will have depression. You'll have, and once you get depressed, then you'll start losing weight. You have no appetite. Um, you'll go further into depression. Even your social relationships suffer. Um, some people may think of suicide at that point. um, Plus also, people treat you differently, like people talk to you like you're stupid. um, and that's the hardest part, is you're cognitively intact. It's just your body not responding, unable to respond, but then you're in your mind, you're completely sharp. So safety is your number one concern. And as I already mentioned, the aspiration here is your greatest priority. Mobility, again, falls. Oh, I forgot about the bowel and bladder problem. So it could range between incontinence and constipation as well. So you can also have same thing for the bladder. So bowel and bladder, you'll have alternating incontinence or even urinary retention. And we haven't even gone to the side effects of the medications yet. Please look at the side effects mentioned earlier. For nutrition, they have to be given modified consistency to promote swallowing, prevent aspiration. When at the hospital, so you should have all these equipment if needed. And for the retention of bladder or bowel retention, stool softeners or increased fluid intake and fiber. Um, so you collaborate with these professionals. Communication, again, do not talk to them like a child um, or loudly, because they'll be slow to respond. They may have difficulty talking in general, so you may use communication boards, for instance, to make it easier, but never assume that they can't understand you, which is what we tend to do if somebody doesn't communicate very well. That will include myself. I'm guilty of that also. Any question on Parkinson's? That's it. Let's go.
Professor, I have a question. One question.
Yep.
So, if they're like genetically predisposed to it, right, and it might manifest itself later on or whenever it does, is there like a way to sort of like not prevent it? You can't almost prevent it, but like maybe delay it, or like, you know, when they're younger, or no? Like, there's no way.
There's always something like that. Like you have supplements, you have brain supplements, you have activities they say to keep the brain sharp. But you think Muhammad Ali and Michael J. Fox didn't do that?
But I don't know. Did they know like that they were predisposed to Parkinson's? Maybe it just manifested
Uh,
like as a result of stress or something, or with Muhammad Ali because of the amount of punching he got in. I don't know. Like I'm just
I don't know. I really don't know. I mean, they have, eat healthy, just like with prevention of cancer, something like that. But do they work? I don't know. We have no data. There's all these conspiracies, like for instance, uh, in Japan, they have the technology. I read a journal wherein they they had the ability to test for um, the likelihood that you'll develop. I mean, what I'm trying to say is you can predict now, they have the technology to predict whether or not you will develop Alzheimer's or Parkinson's and other neurologic disorders. But it's also a double-edged sword. So let's say we have that ability. What now? So let's say Miss Tatiana, you get that test done, and then you find out, oh, yeah, you have a high risk for developing Parkinson's or Alzheimer's disease. Now what?
With Alzheimer's, like I would read more, like make sure my mind is engaged in a lot more stuff so that,
But also you will drive yourself crazy knowing that you...
Exactly. So it's a double-edged sword. You find out, but then now what?
I know.
That get depressed.
Yeah, so let's say you're tested now, you're only 20 years old. Don't tell me that you're gonna, for the next 50 years, that's all you're gonna be thinking of, right? So,
No, God forbid, but at least we can take like lifestyle measures or something like that. I don't know.
but again, we have no evidence of those.
And what about stem cells?
Sorry?
Stem cell, like that's
Uh,
like the new thing that
they have
they're coming up
not
with.
done that for, I mean, they've done that for cancer and some um, hereditary disorders like sickle cell, for instance. They've tried those and those work, but I don't think they work for Parkinson's or Alzheimer's. There's no studies for that yet.
I see.
All right, so this Alzheimer's will be quick. You must have done this already in fundamentals, right? Yeah, I saw this in the fundamentals syllabus or module. Right, so in Alzheimer's, this is, like I mentioned earlier, this is a shrinking of the brain. So your brain cells deteriorate, and on MRI or CAT scan, they see these plaques, or what they call strands. Okay, these are, no, it's not strands, they're like fibers or something. I forgot the term. Anyway, so there's a shrinking of the brain here. So your brain mass decreased in size. So all functions will, of course, decrease. It will vary, symptoms will vary according to the stage of Alzheimer's. Which they don't include here, between early and moderate and late stage. Okay, so they just have general descriptions here about the signs and symptoms. So here, the patient will forget about the early stage, because really in early stage, that's like you and me. We forget, we misplace stuff. And so that means we are also in the early stages, right? So we'll just stick with the late stage. Now the patient starts to wander. Previously, they're familiar with places, but now they get lost. They could get lost for, like my grandmother, maternal grandmother. There was one time she disappeared for 3 days. She was missing for 3 days. And then she came home. She wasn't dirty. She was wearing the same clothes, but then she wasn't dirty. It wasn't like she laid on the dirt. So somehow she must have gone to someone or somebody. Of course, she couldn't tell us. She had no recollections that she was gone for 3 days. She just came home just like nothing happened. And of course, when you ask her, she has no idea where she's been, because all she thought was, well, I left this morning. So this is the danger here. When wandering starts, we do have several technology now. We have GPS trackers, although the range will vary per brand. We have one for our daughter, which we ended up not needing because she doesn't. We have a daughter with autism. She doesn't wander anymore for some reason. She stopped doing that. She stays close to us most of the time. but we still, have it on her, which has a 300 feet range, which is good enough. Um, but for these people, what we did for my grandma was put um, her name and phone number on all of her clothing. So we put that on the back. That way, whenever she's lost, somebody was bound to call, which worked a lot. With There was a time she kept going up the hill where we lived. There was a golf course up the hill, and she'd go there almost every day. So the security, of course, when she ends up at the green, so they'll call, your grandma's here, and we go pick her up. I think it's because she lived in a hill, in a hilly, her house was on a hill when she was still living by herself. So I guess she's, that memory of going up the hill, she thought she was going home. And the late stage, of course, the decline here is really severe, wherein they forget everything, as simple as eating a meal. They forget how to eat. They don't know what to do with the thing. You give them something, they wouldn't know what it is. Let's say a fork, for instance, and a plate of food, they wouldn't know. They wouldn't recognize what is that. What am I supposed to do with it? So these are now the death will come because of infection, pneumonia, falls, malnutrition, dehydration. My grandma died of pneumonia, but it was really peaceful. She just took a really deep breath one morning and then passed away.
Professor, why pneumonia?
We have no ideas. There were a few days leading up to that wherein she wasn't getting out of bed anymore. She couldn't go upstairs. She was so weak, so we put a bed downstairs, so that's where she lay, and she would lay for a long time, and there were no symptoms. She didn't have fever, um, and we didn't know that was my brother's thought. So he didn't bother with a uh, autopsy. He just concluded it was pneumonia. Okay, so atypical pneumonia probably because she never had symptoms. There was no shortness of breath or anything like that. And she wouldn't eat anymore. The past very little the past few days. So, but it was very peaceful.
That's good. Residents of
Yeah.
for long.
Medications. So questions on the test will be on your medications. We have two which are used frequently. We have Namenda, which is memantine, and what is the other one? Um, Namenda and starts with a D.
Aricept.
Aricept, yeah, donepezil. Yeah, thank you. Aricept or donepezil. So those are the two main medications. Some people may be given um, medications also for the symptoms because on top of that they may develop depression, so they may be put on antidepressants as well. So summary, these are your signs and symptoms, and here are your um, nursing interventions. Okay, so safety, oh, here it is. Table 36-8. So we have Aricept, donepezil, and Namenda. The others, let's say for Exelon really is for more for it's antidepressant. Um, but the two main medications are Aricept, or that's donepezil, and memantine. So I'm only testing donepezil and memantine. Any question on drug therapy? Okay, as far as nursing care, because this will be this will require a lot of patience. These patients, the memory is incredible. They have good long-term memory and no short-term memory. It can get annoying because they'll repeatedly ask you the same thing because they are incapable of retaining any short-term memory. But the long-term memory is somehow intact. I already mentioned depression. Okay. Now for how you deal with that is, let me see if they have it here. Um, it's reality validation. Okay, anyway, so for early stage dementia, you may provide reality orientation. You can reorient the patient, right? So that's fine during the early stages. And these are some of the things you can provide, clock, calendar, or familiar, pictures of family members. That's for early because they still recognize people. Later in the later stage, they're fixated. It's not like they don't remember the family member. They just can't recognize them anymore. So because let's say um, you have a daughter, right? So let's say I have a daughter. My daughter grew up already by the time I have late stage. So I won't recognize my daughter because I remember my daughter as a small child. So that's my reality. Okay, so you can't use reality orientation anymore because it will just result in anxiety and aggression because you're insisting to me that my daughter, are you calling me crazy that my daughter is 36 years old? No, my daughter is 4 years old, right? So that's what the patient remembers. That's her daughter. My daughter is 4 years old. She's not 36. All right. So now you can only do validation therapy. You can also do reminiscing during the later stage because again, the long-term memory is intact. So with short-term memory, if they start doing the repetitive question, the main thing to do that there is no more reality orientation. Doesn't work anymore. So you do validation therapy instead. So you just help them reminisce old memories and ask them questions about what they remember, right? Don't say, um, I'm not saying also in a disrespectful way wherein you end up making fun of the patient. Say the patient's 97 years old, and then they think that their mother is still alive, and then some people may make fun of that. They say, "Oh, where's mom now?" You know, of course you don't do that because mom is dead long time ago. So you just ask them about, okay, so what do you remember about mom? Okay, what does mom like to do? Okay, so things like that, right? So that's called validation therapy. You again do not insist on reality orientation anymore. Do not use that for late stage Alzheimer's. It'll just aggravate the patient, cause unnecessary anxiety, and may cause further confusion. All right. So instead, do validation therapy. Just ask them things about what they remember about their mom or their daughter, for instance. Okay. Any questions? Okay, some of the problems also with sleeping, because again they get disoriented whether it's nighttime or daytime, especially during dusk or dawn. So they can't tell the difference. Okay, is this sunset or is this sunrise? Okay, they can't tell. So that will also contribute to the wandering. And the rest of these, especially the nursing care, please read them on your own. For instance, what would be the best room for this patient in a hospital unit?
Close to the nursing office, nursing station.
That's what you see, right? In practice.
Where you can now see them.
Yeah, but if you think about it, is that really the best place? A noisy room next to the nurse station.
They're confused. They keep on getting out of bed and the high risk of fall.
I
But
know.
they
So
get
that's
disturbed very easily, no?
yeah. So that's what I'm saying. That's the
But they should be
practice,
far
but
away.
that's not best practice though. Really, the best practice says they should be in a room as far away from the nurse station as possible because they need less stimulation. And the best practice is to put a sitter with a patient. You may say, oh, we don't have sitters, but again, NCLEX is a perfect world,
That's
right?
right.
Yeah, there is no nursing shortage. There's no sitter shortage on the NCLEX. All right, so the best place for the NCLEX, only on the NCLEX, is to put them in a room far from the station with a sitter.
So a 1-to-1.
Yeah, yeah, 1-to-1, close monitoring.
If they're confused, they don't sleep, they get out of bed, they fall.
Yeah, exactly. So do 1-to-1, put a sitter, but don't put them to a room in a room next to the nurse station. Okay, they'll
You
never
know,
sleep.
you know what we do? Either we put them close to the nurse station or we put them by the nurse station and monitor them
Yeah, you put them on a chair, right?
on a share.
Yeah.
Yeah,
Now they'll never sleep.
they'll never sleep. They don't sleep. They stay there 24/7.
Oh boy. Okay, so let's take a break. Come back at 10:20, 10:30.
Okay, thank you.
Thank you.